Okay, before you can understand how medications for Alzheimer's disease work, you have to understand what Alzheimer's disease is. Okay. Now look at this one. I brought a picture here for you to understand what is going on in people like this. We have a common question around between the differences between among the difference between dementia and delirium. Okay, dementia and delirium. So normally, I I give a trick that if you want to understand, the delirium is a temporal something. Okay, it's a temporal form of all those changes that happen. But dementia is progressive and tends to be permanent. Okay, it happens when there is a like even structural change, okay, or structural changes within the brain or other things. Okay, so what I normally tell people is that we can associate dementia to Alzheimer's disease, then you can be able to make the differences easily because that is what is pronounced more in Alzheimer's disease. Okay. So you see speech or writing changes, visual changes. There will be altered mental status or judgment, problem solving changes, personality or mood changes, social changes. They tend to misplace things, then they have memory loss. All these are not temporal changes. They tend to be progressive and tend to be permanent. Okay, yeah. So let us look at in summary. I have a summary table here just to sum up all that is going on in Alzheimer's disease. Then we look at the treatment modalities. Okay. So we are saying it's a progressive neurodegenerative disease causing memory loss, okay, and cognitive decline. So one there is it's a neurodegenerative disease, and it causes memory loss and cognitive decline. Okay, and it is caused by. So look at the causes. The causes will uh, help us reflect on how we can solve the issue. So with the cause of Alzheimer's disease, it has other things. Okay, like amyloid plaques and neurofibrillary tangles. These are like structural changes in the brain. Okay, but let us look at the neurotransmitter part. Okay, so it is caused by low acetylcholine. Okay, and these structural changes within the brain too. After, I would want us to compare all that we've done, starting from Parkinson's. We are doing Alzheimer, right? After, we're going to do myasthenia gravis. Okay, and they all talk about these neurotransmitters. So we will look at how, they are, what is happening in all of them. Okay, so that I'm sure it's going to be very easy for us. Okay, I pray so. I have like I pray the presentation goes well for all of us, and I'm trying to make it a bit easier so that we can never forget. Okay. All right. So remember, in Parkinson's disease, you had low dopamine rather, and the acetylcholine was high. So you were trying to increase the dopamine levels in Parkinson's disease and reduce the acetylcholine. Okay. In Alzheimer's disease, you have acetylcholine low, which is causing the disease. Aside this, amyloid plaques and neurofibrillary tangles. Okay. Yeah, so we'll look at this one later. So the risk factors for Alzheimer's disease is old age, family history, head injury. So according to recent researches, I also found out that they even want to add it up to autoimmune diseases. Okay, and even with Parkinson's disease, even though they are all neurodegenerative diseases of the brain, but it's like they are now trying to see an like autoimmune factor in these diseases, right? So just to let you know, early symptoms that you could see. So we looked at some of the symptoms here. Okay, all of this happening in Alzheimer's disease. Um, what we have here is memory loss, confusion, personality change, and poor judgment. And some of the late symptoms you can see is that they cannot even recognize you. If you are their brother, their sister, their mother, they cannot recognize you. That is when it gets to the extreme part of it. And so you see why we say it's a permanent thing, like it's a continuous something, and it causes permanent damage to the brain. Because if it were temporal, these things wouldn't be there at the late stage. Okay, so they will have part of the brain which controls speech affected. So they cannot speak, they can't even walk. Okay, and swallowing will be very difficult for them. So how we diagnose Alzheimer's disease? We have mental status tests. Then CT scan and MRI tool will help to identify the structural changes in the brain. So these are used to help us diagnose Alzheimer's disease. Okay. Now with the drug class that is used, so our main aim, the drug class that is used to solve Alzheimer's disease is the cholinesterase inhibitor. So we're going to talk about this. You see, we have acetylcholine. Please, this is the same as acetylcholinesterase. Okay, when you hear of cholinesterase, it's the same thing we're talking about. But look at this. When you hear of the sterase, forget about the inhibitors. I want you to understand this right from here, so that because we'll be using it a lot. Okay, forget about inhibitors prevent the action of things. This is just English. When we say something inhibits, it's just English word. But let us look at this one. When you say cholinesterase, when you see this word sterase is an enzyme that degrades something, like it destroys something. Okay, so that is how I want you to understand this part, so that you'll be able to get what we are about to present ahead. So when you hear sterase is an enzyme that degrades something. So cholinesterase, what comes into your mind? When you hear cholinesterase, with the explanation I've just given, what should come into your mind? Who wants to try?
Jacob.
It's very simple.
It means that they destroy
the cholines.
Good.
Destroy cholines.
Good. So an enzyme
acetylcholine
that destroys acetylcholine. Good. Or acetylcholine. Some people will call it that. Okay. So cholinesterase is an enzyme that destroys acetylcholine. That's what I want you to understand. So when you have cholinesterase inhibitors, it means, okay, let me also leave it to you. Who understand that one too? When you add the inhibitors, what does it mean for the whole thing here?
So
okay, and I can.
It means that okay. Sorry. So it means that we've been told, or we know that the cholinesterase destroys the acetylcholine. So over here, probably we don't want acetylcholine to be destroyed. So we want medications that will help us, avoid destroying the acetylcholine. So they prevent the acetylcholine from being destroyed.
Good, good, good. So that's exactly what we want to say. So by doing so, what will be our levels of acetylcholine, like at the end, will it increase or will it decrease?
It will increase.
So it will end up increasing acetylcholine, which will counteract the effect of the cause. Have you seen it? Because the cause is that you have acetylcholine becoming low. That is why you can get Alzheimer's disease. Okay. Please, this one is within the brain. When it comes for us to link all together, you understand. So this we are talking about this all these things we are talking about. It's within the brain. Don't think about other external parts of the body. So all these changes we are seeing, it's within the brain. So I want you to focus on that. Okay. So if at the end of the day, this drug will end up increasing acetylcholine, then it means we can have our treatment modality, okay? Or we can have our cause being treated. Okay, so that's what it means. So we use choline series inhibitors. We look at them, okay, what kind of drugs they are to treat Alzheimer's disease. So some of them are donepezil, rivastigmine, okay, galantamine. So I think these three, they are very common, especially the first two. You see it in kill banks and wherever you have questions. Okay. Yes. So rivastigmine, galantamine, and donepezil. These are examples of what choline inhibitors. So they prevent the degradation of acetylcholine, okay, and therefore will help to increase the presence or the concentration of acetylcholine, and that's in the brain, please, precisely in the brain. I'm stressing on the brain because when we get to myasthenia gravis, I will link it up so that you see the difference, okay? So in the brain, it increases acetylcholine in the brain. That's how they've been modified to do. Okay. All right. Then we have another drug which is called memantin. Okay. We have a class for it. It's an abbreviated word. We will look at that. And what memantin ends up, when you look at the mechanism of action and everything, what it does in short at the end of the day is that it will help preserve nerve function. Okay. So looking at amyloid plaques and neurofibrillary tangles, okay. Looking at this aspect too, it looks like memantin can help because this one causes structural changes uh, within the nerve cells, okay. And memantin can help preserve the nerve function and the structural changes. Okay, it can help preserve it. So that is why we have memantin to be another drug that helps in solving Alzheimer's issues. So how do we care for them? Looking at all this, because they have memory loss, confusion, personality changes, at a point in time, they even do not recognize their family. They cannot walk. They can lose their way wherever they are going or whichever. So the main concern is safety, and you keep on reorienting them. They can eat and forget they've eaten, okay, and all of that. So you keep on reorienting them, and you give them simple and short instructions. So there are questions too on this one. If you want something from them, like let's say if you want them to make a choice, you either use yes or no answer. Okay, if it's pictures, you can make it in pictures. You show both options to them, and they choose what they want. You don't have to talk plenty. Okay, so you use close end questions, not open end questions. For a normal person or generally, when you're having a conversation, it is always therapeutic to use open-ended questions so that you can get a lot of information from them. In people with neurodegenerative disease like this, open-ended questions become a wrong choice you use a close-ended question. Simple instructions, yes or no. Okay. All right. When it comes to their nutrition, you also should take note, because they have, depending on the stage that they've reached, they are swallowing and all of that, and you have to give them highly nutritious food too. And they should follow a particular routine. Okay, you don't have to change a lot of routines for them. It makes them more confused. So you follow a particular routine for them. So the key facts of this disease is that it's progressive. It doesn't stay where it is, even though we have treatment for them. So the treatment is not for them to come back to their normal cognitive state. Okay, it is to prevent the progression and worsening of the disease. So the disease itself is not reversible. Okay. Normally I say I have a funny say, or let's say I have something that I normally put it in this way. When a nerve cell dies, it dies. Okay. What is left, you can protect it. But what is dead and gone. Mostly that is how nerve cells work. It's very difficult for you to recruit them, okay, to come into function like as they were before. It will be difficult for you to do that. That's how nerve cells are. Okay, so if you are here and you are taking um, medications for your eye, especially glaucoma, glaucoma affects your optic nerves, right? So if you are here and you are taking the drug, or you know someone who is taking the drug, encourage the person to take it very well. The drug itself will not make you regain your sight or something like that. But where your vision has reached, okay, the drug prevents it from worsening. Some people will be like, even though we are not doing eyes, but no, because it's all about nerves. I just want to link it to that part. Some people expect that when they take this timolol and other glaucoma medications, they want their sight to regain. Okay, they want to see clearly as they were doing before. It's not like that. It protects you from getting worse. But if you don't use it, you will see the progression of the disease. And wherever it will degrade to, should you start using the medication again to protect you at that point, it will not bring you back to even where you were. That is why you can't miss medications when you have disease, when you are taking drugs for, I mean, neurologic conditions. Okay, you can't afford to miss doses because they are very difficult to fight. Any question on this one? Okay, now let's look at the drugs themselves. Okay, so medications used to treat Alzheimer's disease. The main diseases. The main drugs are here. So this is an abbreviation for a big term. I don't even want to go there. Okay, but maybe later you will see what it is. But this is what it does. Okay, at the end of the day, the medication will help improve memory, thinking, and behavior. All right. It will not cure you from Alzheimer's disease, like we said before, but it will help to slow the progression of the symptoms. Okay. And these are the two main drugs. These are the two main drugs that are used to treat Alzheimer's disease. So the cholinesterase inhibitors, like we talked about, they increase acetylcholine in the brain. Okay, and we've talked about how they do that, right? They prevent the inhibitors, okay, cholinesterase inhibitors, they prevent the degradation of acetylcholine, thereby increasing acetylcholine in the brain. And when they do that, so they are going to improve memory and cognition. All right. So the next one is the MDA receptor antagonist. MDA is like N-methyl deaspartate receptor or something like, yeah, deaspartate, yeah, N-methyl deaspartate. Normally, should you be giving this drug, they will always quote NMDA. So NMDA is okay too. So just keep okay. So NMDA receptor antagonist. Um, you see what it does? It protects brain cells from damage and it slows the disease progression. So like what we were talking about here, okay, all these amyloid plaques and neurofibrillary tangles that causes structural damage to the brain. This NMDA, like so, NMDA, an example is memantine. Okay, so memantine is a type of NMDA, so it helps to preserve the nerve. Okay. Any question on this side? If no question, move on to the next one. So here they made very simple and easy here. So the choline sterase
So please
inhibitors,
for
we have
the
the
previous slide. Thank you.
you have a question? Okay.
Oh.
So we have choline sterase inhibitors, which we have the rivastigmine, donepezil, and the galantamine. Okay, and the other one is the memantine. Okay. Now let's look at administration considerations. Give between meals. Let me ask you, what does this one mean? I think there was a time someone asked me a question, like when you say give between meals, is it like when you are eating, then you take it, then after you continue eating or something? Because it says between meals. Who understand this statement? Who can help us? Because give medications between meals. I mean, you see it at a lot of places, not only here. And it's one part of NCLES, one part of NCLES options that normally trick people. So I want us to understand this once and for all. What does it mean when we say give drugs between meals?
Hello.
Yeah, Sister Amma.
So you give it after the person has eaten, like before you eat the next meal. So the person takes it maybe like 30 minutes or an hour after finish. That is how I understand it.
Okay.
Hello, can I come in?
Okay. Omi. All right.
Yeah,
Thank you so
so
much. Omi.
to give between meals is like between breakfast and lunch. So between
Okay.
these
Good.
two times, you
Good.
can take
Good.
that. And then to
Good.
take with meals is like whilst you are eating, then you can have that medication at the same time.
Okay. Good. Good. You have even you have even brought an idea. So
I think I will
so
also
giving
follow
a drag
Jacob.
in between meals, someone also quoted for me that it means we have three meals, like square meals within a day, right? So it's like breakfast, lunch, and supper. So I take it between meals, like between like supper and can be supper and lunch or breakfast and lunch or something. Someone wants to talk, eh? Okay, last person before I come in.
I wanted to say the same thing. I think Brother Jacob and Sister Ma has already explained. It's like you are giving, let's say when you take your breakfast at 8 a.m., and your lunch, let's say, is at 12 or 1 p.m., you calculate, let's say, an hour or 30 minutes. So let's say 10 a.m. you can take your medication before
Okay.
you take your lunch, like 2 hours before you take your lunch. So it's like that.
Okay.
That's how I understand it.
Okay. Thank you. Thank you.
Welcome.
I like all those contributions. So, in a simple and short statement, give medications or giving drugs between meals means that give it 1 hour, at least 1 hour, okay, before meals or 2 hours after meals. So that statement can be used interchangeably to this one. So when you say a medication, that shouldn't go with meals, okay? And let's say they're asking you in an English form question and they're like, give, like maybe select all that apply questions, okay? What instructions or what education about the drug can you give to maybe your patient or to the client? Then they'll be like, give medications between meals. Giving medications between meals is the same as giving it 1 hour before, at least 1 hour, okay, before eating or 2 hours after eating. That is what it means. Okay. And giving it like what our brother said, okay, between breakfast, let's say between breakfast and lunch, it's also within that range, okay, because at least between breakfast and lunch, someone will be so the time is very I'm very much focused about the time because someone will be like, fine, maybe I'll take my breakfast at um maybe 11:30 a.m. Okay, and take my lunch at 12. It's impractical, but I just want to stress on the time. So the time is a fact about that. So before, like 1 hour before meals and 2 hours after meals. That's what it means by taking drugs between meals. Then taking drugs with meals, what that also means is that you are taking the medication, sorry, you are let's say you take the medication right before eating. Okay, like as soon as you take the medication right now, you eat. Or even in the process of eating, you take the medication. Or right after eating, you take the medication. So I mean those three ways. That is like what it means by taking medications with meals. Okay, so you see that as soon as you take it, you eat right away, or even the process of eating, you take it, or right after eating, you take it. So those things are in line with taking medications with meals. All right. Now the next point here is that you may give it. So there's a condition. Okay, if we have some people, some drugs are very irritative to their stomach. So I mean, even though there will be a reduction, I mean, like some sort of reduction in the absorption of the drug, but it is better than to eat and get GI upset. Okay, so if only there is GI upset, you can take it with food. Then you should adjust the dosage every 6 weeks. Okay, dosages should be adjusted every 6 weeks so that you can match up with the changes going on. Then you have to monitor patient response, whether the patient is responding well. So they will have a scheduled checkup that they'll be going just to ensure that the dosages are being adjusted and the response to the medications are also okay. Right. So these are outright contraindications. When you are hypersensitive to the drug, you can take it. And because it's highly metabolized by the liver, okay, when you have jaundice or liver issue, you can take it. When the jaundice is there, okay, when the jaundice is there, jaundice is like it's a sign of it's a sign that your liver is currently undergoing like some form of stress. Okay, you have an active liver disease, so that one you can't take it. Okay, but if you have any other liver disease, so generally serious liver disease is not encouraged. Okay, but when depending on the stage, we have some others that maybe we can take, but it will depend on what your healthcare provider will say. But when it comes to outright conditions, outright contraindications, hypersensitivity, then liver disease, you can't take the medication. Side effects. So with CNS effects, these are what you can get: insomnia. You have issues with sleep. Okay, so if you have issues with sleep, then it means it's best to take it mostly within the day, right? That's what it means. Then it can also cause dizziness, confusion, depression, and hallucinations. Okay, it doesn't mean that you will definitely get all of these things. You can get any of them. Then these are the GI effects: nausea, vomiting, diarrhea, constipation. So you see this one, you can have either diarrhea or constipation, depending on your system. Remember, with opioids, we emphasize mainly on the constipation, but that's what you get. But for this one, you can get any of them. And you can get abdominal pain. So these are other effects that you can also have: urinary frequency, incontinence, rash, seizures, then hepatotoxicity. Okay.
Hello, sir.
If you have any question here, you can ask.
Yes. I want to know, please, can you hear me?
Yes, please.
Okay, I want to know the difference between side effects and adverse effects.
Okay, so I think we've said this here before. Side effects are they are not normally dangerous compared to adverse effects. Okay. Adverse effects normally end up with complications.
Okay.
Okay, yes, they normally end up with constipation. For all of them, you don't want them happening though. But side effects are just something mild. Okay, but with adverse effects, they can end up with even you ended up treating that adverse effect. Okay. So when it comes to like side effects like diarrhea, unless maybe it's causing, it depends. Let me see. If let's say you're having incontinence, okay, it depends. All this can be side effect and can be adverse effect. Let's say if you have insomnia and it's a slight one, maybe you can overcome it. But if it's causing like a continuous one that you can't do anything, let's say confusion too. Okay, if the confusion is becoming worse and something, at least we have to calm you down. We have to treat the it becomes an adverse effect right now. Then we have to treat it. But if let's say it's very mild and you know it's just worse off within a shorter time, which doesn't even require treatment, then it becomes a normal side effect. So normally adverse effects are more dangerous than okay. So it's like diarrhea. When you have diarrhea, let's say just couple of diarrhea after taking these medications and you are okay. I mean that is okay. But when it becomes very chronic to the extent that you are losing lots of fluid, you are very weak and losing. We have to treat the diarrhea. We have to replace all the fluid that you are losing and all of that. So that becomes something like an adverse. That's how I understand
Okay. Thank you.
it. Okay.
Please, one more question. What's the
Okay.
differences between contraindication and indication, please?
Indications is you use it for. And contra indication is against. Contra means against. What is it? Contra Okay, contra is like against. So against indications, against the use of it. Indication means you can use it for it. And contra indication means it's against the use of it. So you can't use it. Please, do you understand?
Yes, sir. Thank you.
Okay. Any other question?
Yes, please.
Mm-hmm.
Yeah, please. I want to understand. You see, in the disease itself, there is confusion, there is depression, and there is hallucination. Here too, the
Mm-hmm.
side effect of the medication too is causing these things. So if you get it in a question that a patient who is on this medication is reporting, or you are observing the patient to be having these symptoms, are you going to just conclude that it's part of the medication, or you have to report to the healthcare provider? That's my confusion.
Okay. So I understand you. So Eckley's question is that fair enough? Okay. In the sense that when they are asking you questions and it's about medications, you know it's about medication. And when it is about the disease condition itself, you know. So let me try and see if I can give you some examples or if I can demonstrate, like if I can think of something and give it to you right now. Let's say you have been asked a question and they are like, a patient you're caring for has been taking rivastigmine, okay, for about 2 weeks. Okay. If they've given you, let's say, a preamble like that, it means the question that they're going to ask you will be relating to what? The drug. Okay. And let's say, and the person has been having increasing confusion, okay, and maybe depression and has hallucination. Within 2, 3 weeks at least, you should see, even if not to its fullest, you should see some small improvement. So if the question continues to tell you that maybe confusion has increased, depression is on its higher side, then what does it tell you? It means the medication is not working. And if it's not working, when I say the medication is not working, it can be like it's a bigger umbrella. Okay. It's either it's giving you the adverse effect of it, because at the end of the day, it should improve your symptoms. And if the symptoms are not improving and they are becoming worse, it could be that the drug is not working in the first place, or you are having the adverse effect. And in all of those things, with regards to your confusion question, they will increase confusion. Okay, so you will know that that question is mainly asked like in relation to the drug because they've given you a preamble. So whenever you get a question, always pay attention to the preamble. The preamble will direct you which one or which area they want. They're asking you the question from. Okay. So normally yes, I think I when we were doing consent form, I demonstrated with one clear example. Okay. Let me see if I can remember. We know that when a patient is going for surgery, nurses are not supposed to what? They are not supposed to take consent form except the doctor, okay, or the surgeon who is going to perform the surgery. He or she has to explain directly to the patient and just take consent. There are some questions they will ask you, maybe there are some questions they will be like, which of the following maybe is maybe the responsibility of the nurse, okay, to ensure maybe for a patient going for thyroidectomy. And the answer could be seek consent, or maybe make sure consent form is signed or something like that. So someone asked, are we nurses supposed to take consent? And meanwhile, in questions like that, The answer, the answer being you, the nurse, should make sure consent form is signed. It's correct. Okay. You have, so questions will be like that. Okay. So when questions are like that, it's like a general question that they're asking you as part of your pre-op preparations. You have to make sure you see consent. It doesn't
Alright,
necessarily
Alpha.
mean that you're going to sit. Are you talking to us?
Yes, sir.
Are you talking to us? Okay. It doesn't necessarily mean that you are going to sit down with the patient and explain everything to the patient. Okay. But let's say when questions come, like, let's say you are maybe preparing a patient for surgery, okay, and just before you send patient, to the theater room, maybe patient asks, let's say the patient is going for below knee amputation, and the patient asks, will I be able to walk normally? Okay, will I be able to walk normally like I used to before, the procedure? When questions like this start coming in, you don't even have to reinforce, you don't have to, if questions are suspicious, you have to refer the patient to the surgeon, okay? Or like I just want to give, I said something in that recording, those of you who remember. Okay, so what I want to draw your attention to is that normally pay attention to the preamble to the question. If it's a pure consent question that they're asking you, always be careful that nurses cannot seek consent. But if, let's say, it's a general question that they're asking you as part of your responsibility as a nurse, seeking consent is an answer. Okay? Seeking consent is an answer. But you yourself, you can't actually take a whole consent from a patient who is going for surgery or from a procedure. And when the question begins, you will know that this question is mainly a consent form question. So that one, don't go there. Leave questions and actual consent form, the take of consent form from patient, leave it to the surgeon or to the doctor. Okay, so that's the point we are trying to say here. So with confusion, back to what we are doing with confusion, if the preamble is like patient has been taking the medication for some time and you can link whatever thing to the medication. If it's just the condition, then you can link it to the condition, because in both sides they are all there. So it depends on what the question is asking you. Do you understand my point? The point I'm trying to make. Do you understand? The one who has the question.
Yes, yes, please. I understand. Thank you so much.
You are welcome. Any other question from anyone?
So, boss, hello, boss.
Yeah.
So, I just wanted to find out if maybe the side effect of the drugs also included memantine. Memantine side effect is almost same as the cholinesterase.
Yes, please. It's inclusive. Okay. It's inclusive. It's part of it.
Okay. Okay. Thank you.
All right. You're welcome. Okay. So now let's look at I hope you've seen this. Okay, rash, seizures, and all of that. Now let's look at nursing considerations. When you are giving this medication, you have to monitor patient's blood pressure, because likely it sometimes causes hypertension. Okay, not always, but just have to monitor blood pressure. Very important. So this is like normal vital signs. Even heart rate, you have to monitor, and you have to assess patient mental status. It's part of the diagnosis. So if they are doing well or symptoms are improving, you will know during your mental status examination. Okay. Then you have to monitor liver enzymes, okay, or other liver functions. You have to monitor GI side effects, monitor urinary incontinence. Okay. Then evaluate for confusion decrease. Okay, so these are the desirable effects that we want. So you have to evaluate whether confusion is going down, memory, or let's say mood is being improved. Okay, then cognition is also being improved, but not getting worse. Client teaching. So this is to tell you that the medication will not cure Alzheimer's disease. These conditions cannot be cured. Okay, so it will only slow the symptoms. All right, it will only slow down the symptoms. Then you have to take it with food if you have GI abscess, like we said. Okay, so you see this one, you report if you have these things becoming, you see, when it comes to overdose or toxicity of any drug, the GI symptoms are likely to be the first. Okay, do you remember lithium and digoxin? It got to a time they were very high and close questions people were getting. Okay. Early signs of lithium toxicity or digoxin. Most of the time they are likely to be the GI symptoms. So you see nausea or vomit. Sometimes they will not even bring all, like they'll bring just nausea. Okay. And sometimes they'll add maybe nausea and vomiting. So those are normally the earlier symptoms that come. Then you can have sweating, then twitching. Okay. When twitching happens, then twitching normally becomes part of the late symptom. Then it means something very strange is happening. Okay, so key point to take home. Okay, key point to take home for these drugs. We are saying Alzheimer's drugs increase acetylcholine. Okay, we've established that already. Memantine protects brain cells from being destroyed, and you have to continually perform mental status so that you know whether there's improvement or not. You have to monitor for liver function. Then also have the idea that it's not a cure, but only for symptom control. Okay. Yeah. So I think that ends Alzheimer's disease, drugs, and everything. If you have any question or any addition, you can bring it up. Because I have a question for you. Some questions for you. Any question, any addition, any subtraction? Or you are ready for my question? Okay. Can we get a reader for my questions? Any reader available?
Yes.
Please, let's go.
The nurse recognizes that this medication acts by A. Blocking dopamine receptors, B. Increasing acetylcholine levels in the brain, C. Decreasing serotonin levels, and D. Enhancing GABA activity.
From what we've learned, what do you think is the answer?
B. B.
B.
What's the answer?
B.
B. Yes. Who doesn't understand this is B? So should he get any question like this or similarly anywhere, he should be able to answer. Okay. That is B. All right. Our next question.
The nurse is providing discharge instructions to a client with Alzheimer's disease and his family. Based on the knowledge that the prescribed medication therapy will not reverse Alzheimer's symptoms, what should be included in this discussion? 1. Keep the client in his own home, regardless of circumstances. 2. Provide supervision to protect client from being injured or lost. 3. Encourage the client to interview potential home care agencies. And 4. Postpone the use of adaptive assistive equipment. Oh. Equipment as long as possible.
The answer is what?
2.
Two.
Provide supervision.
The answer is 2.
All right. We all agree. All right. So the answer is 2. Okay. So look at this one. Clients with Alzheimer's disease are at risk for. So you see, wondering. Okay. Like I was saying. Okay. They can get lost and they can injure themselves, like wandering. Not their fault. All right. So you have to provide continuous supervision. It's like a daily something every day. All right. Okay.
Please let me see the question.
Come again.
Please let me see the previous answers, please.
This is the question, and this was the answer.
Okay. Thank you.
Or you want to see the question? Okay. All right. So this is our next question.
The nurse prioritizes which problem to be of greatest concern for the clients newly diagnosed with Alzheimer's disease who is just beginning medication therapy. 1. Possible altered fluid and electrolyte balance. 2. Generalized discomfort. 3. Interruption in normal sleep patterns. And 4. Disturbances in thought process.
3. The answer is 3. Insomnia.
So which one is the answer?
3. Insomnia.
Do we all agree with 3? Someone said 3. Do you all agree?
Yes. Insomnia.
Why the rest of us are quiet?
Maybe they are now reading through.
Okay, I'm waiting. The previous one, we had lots of responses agreeing.
Side effect of the medication.
Mr. Beatrice, what's the answer?
From the quintessential archives, I think the answer is 3. The answer is 3.
I'm thinking of 4.
Beatrice is thinking of 4.
I'll support the 3.
Okay, so between 3, only one person is choosing 4.
In the thought process.
Okay, so we have done well. Only one person got it correct.
Yeah.
Yes. This was a tricky one.
Yes, because of the thought process I saw, the person has issue with dementia and the confusion state.
Dementia.
Yeah.
Is dementia cognitive impairment?
Yeah.
So why?
Please, can you go back to the question again?
Why will you choose aside?
Can you please go back to the question
sorry,
again?
this is the question. It says a nurse prioritize which problems to be the greatest, to be of greatest concern for the client who is newly diagnosed with Alzheimer's disease.
Okay. Sleeping pattern cannot be a concern.
Yeah, it's for the.
Good. So even look at this one. Those who were even choosing insomnia, who is just beginning. The person is just beginning with medication. Okay. So the answer is disturbance in thought process. Okay.
So
you normally get you normally get the insomnia after some time, okay, after taking the medication. And this one, the person is just beginning the medication therapy. And even if insomnia has even set in, between insomnia and disturbance in thought process, which one will be of greatest concern? That's also another question to ask.
Okay,
yeah, someone wanted to ask a question.
Yeah, that was my question because I wanted to add that since it's a priority question, it means like the two options can be correct, but one supersedes the other one. That's why
Yes.
the answer
Yes.
is disturbance of thought process.
Yes.
Okay.
Yes. Remember, we said in necklace questions, they are normally not going to give you an awkward questions like an awkward option. Okay, they will not give you entirely awkward option. It's only in few cases. They will normally give you
Sure.
options which are close to the correct answers. Okay, can we move on? Our next question.
The nurse should include which items in an assessment of the client with Alzheimer's disease who is receiving rivastigmine? 1. Blood pressure, mental status, and gastrointestinal status. 2. Hemoglobin, white blood cells, and liver function tests. 3. Age, GB, red blood cells, RBL, and mental status. And 4. BP, electrolytes, and edema in legs.
Mm-hmm. Is it a tricky one?
No, one more.
One, between one.
Is someone joining with two devices? Or maybe a headset
Go
or
for
like
one.
maybe something like that. What is the
I'll go
answer?
for one. I'll go
We'll
for
go
one.
for one. Because
Me
his
too,
liver
one.
is
Do we all
contraindicated.
agree with one?
Yeah.
Are you
Yes.
sure? Are you sure the answer is one? So should you get it on the
Yes.
inclusive one, right?
Yeah, I'll choose one.
Yes.
Very sure.
Today, but today my people are brave. Oh. Well done.
Eh, yes.
Yeah, well done. Okay, so I brought one question just to sway our attention to something, okay? Or let me say just to draw our attention to something. Let's see. Yeah, so this is the question. I saw it somewhere, but I decided to bring it here for us to have a look at it. So kindly read it for us.
A client healthcare provider has prescribed amitriptyline as prophylaxis for migraine headaches. The nurse should warn the client about which over-the-counter medication that might intensify the actions of amitriptyline. 1. Acetaminophen. 2. Aspirin. 3. Naproxen. And 4. Cimetidine.
Mm-hmm.
4.
So one or two.
It's not selected that apply. It's only one question, one answer.
Cimetidine.
It's submitted in. Why do you choose submitted in? Do you know why?
It's because the condition is mostly in aged, and cimetidine used in aged has some effects.
Okay. Some effect. Okay. Okay. So you have an idea. So yes, that's why I submitted in. So the main effect is that it increases the amitriptyline levels, okay, in the body, thereby getting to toxic levels of the drug, and lots of issues can happen. So I just wanted to bring this here. As part of when we were doing migraine, I should have brought this question in migraine. All right. Can we have our next question? This is just by the way, okay?
A client taking galantamine reports nausea and diarrhea. What is the nurse's best response? A. Stop the medication immediately. B. This is an expected side effect. C. Double the dose. D. Switch to another drug immediately.
Mm-hmm.
I'm thinking of A. At the same time,
What's the answer?
B.
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 B. I
Do you
think
all agree to B?
not
Yeah,
really, because when
B.
the
No.
teachings, it says that the patient should report nausea, vomiting, sweating, but it's also another side effect. Anyway, please, I'll go for A.
A.
You go for A. Eh?
Mm, because based on the slides, when we were talking, when you were teaching us, you said when the teachings, the client should report nausea, vomiting, and sweating, and maybe it can be possible overdose. That's what I understood, even though it's a side effect. But anyway, that is me. I'll go for.
So you go for A. So so
Also
so, so in this
medication.
I'll go
question,
for A.
has the question told you that there is an overdose or
The,
something?
the answer is B.
You see, the question has not told
I will
us
go for
more
B.
as
Mm-hmm.
the question has not given us an idea that there is an overdose. Okay, so that's how to reduce your answers.
Okay.
Okay,
Okay.
yes. If the question had given you maybe if there's at least if there's an adverse effect, most of the drugs you can't stop abruptly, please. So when you hear you right, if you're Rosie, we hear you. So most of the drugs you can't stop abruptly. Okay, you
Okay.
can't. So be careful when you see options like that. But please, when let's say a patient is having, let's say, a serious adverse effect, please, even if the medication is not to be discontinued abruptly, stop the medication. You know that when you are giving vasopressors, okay, when you are giving vasopressors or these inotropes, like when you are perfusing, even in real case scenarios, you are not supposed to stop them abruptly too. Okay, you have to taper the dose down until you get to the lowest level before you can then take it out. Okay, or before you can stop it. But if patient is showing serious adverse effects or even a reaction, please, for all medications, you have to stop it. It is like blood. Okay, you are giving blood, patient is reacting to it. Please, safety first, stop it. So that one, you don't follow the normal protocol. You have to, protocol in stopping drugs, okay, or tapering drugs. Or please, if the person is reacting, stop. Is that part clear for us?
Yes, sir.
Okay. Our next question.
If statements by the client indicate correct understanding of Alzheimer's medication therapy. A. This medication will cure my disease. I can stop the medication when I feel better. This medication will help slow my symptoms. I should take it only when symptoms worsen. C.
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 B for boy.
C. A.
C.
Not
C.
correct
C.
C for
understanding.
cat.
C.
C
C
for
for
cat.
cat.
B for cat. Yes, that is correct. I thought you said B.
No.
Okay. All right. I think this will be our last question. Then we can continue.
A client taking
Mm-hmm.
Alzheimer's medication develops frequent urination and incontinence. What should the nurse do? A. Ignore the symptom. B. Document and assess further. C. Stop medication immediately. D. Restrict fluid.
A.
Mm-hmm.
Hey, babes.
B
Beginning
for
something
boy.
new.
B for boy.
Document and assess
Okay.
further.
Yes, please.
Yes, B for boy. This one too is very easy, right? Easy peasy.
Yep.
All right. Now, here comes our next one. Medications used to treat myasthenia gravis. Okay. So,
Sir,
after
please
this
may I
one,
ask you the previous question? Okay, thank you.
okay. After this one, we're going to look at one last thing like skeletal muscle relaxants. Okay, some drugs that are like the dantrolene and those things. Okay. After this one, we look at that one, then we'll end this first session of our pharmacology. Okay, musculoskeletal and neurology. So we combine two, and we are done. All right. God, if God permits, tomorrow I'll announce maybe our next step. Okay, I'll announce it to all of us so that we know what is ahead of us. Okay. So myasthenia gravis. When we say myasthenia gravis, what comes into mind? When we say myasthenia gravis, what comes into your mind? Those of you who have done neurology, you've met it before.
I know that it is autoimmune neuromuscular disease
Okay.
disorder. That's what I know, like autoimmune neuromuscular disorder. Yeah.
Okay. Okay. Thank you. So when we say myasthenia gravis, most of the times you see it in the face, but it doesn't happen only to the face. Okay. It happens at neuromuscular junctions. So it means anywhere around your body it can happen. Okay. So this is what you see over here. Okay. You see drooping eyelids. You're going to see difficulty breathing. You're going to see changes in facial expression. You are going to see slurred, like blurred vision, slurred speech, trouble moving, trouble moving the neck. Okay, you see muscle fatigue. You see difficulty chewing and difficulty swallowing, arm and leg weakness. You see all of these things. Okay, you see all of these things happening. All right, now um, we have identified the fact that it is autoimmune disease. Okay, we will look at what happens over here. Okay, I brought this picture here just to explain to you what is really happening. Okay, I'll go through with you right now. And when we say autoimmune disease means that the body itself is attacking. The body is the immune system is attacking itself. Okay, all right. And the main problem with these people is that they have muscle weakness that worsens with activity. And the key thing is it improves with rest. Listen to this part very well. With myasthenia gravis, even though there is muscle weakness, that worsens with activity, but it improves with rest. Okay, you see all these things happening. Okay, the drooping face and all of that. All right. Okay. We'll look at how to diagnose it. It's part of what we are coming to do. Okay, the diagnostic test and all of that. The first line drugs, we'll talk about all of them and how we can treat and everything. All right. Now look at what is happening here on your right hand side. We are saying it's an autoimmune disorder that causes the distraction of what? Acetylcholine receptors at neuromuscular junction. So let me pick up my pen. Let me show you something here. So you see, this is a nerve cell, okay? This is a nerve cell here, and this is a muscle, like a muscle, okay? So we have neuro and muscle junction, so neuromuscular junction. So where this arrow, this red arrow is coming from, that's the junction between the nerve and the muscle, so neuromuscular junction. Over here, the neuromuscular junction, that's what is happening. That is what has been projected and opened up large over here. Okay. So look at this. You see, we have acetylcholine receptors here. Receptors means it is receiving something. Okay, like just understand receptors as something receiving something. Okay, so those purple colored Y shaped structures here, they are acetylcholine receptors, right? So with that Y shape, normally, you see, for you to have a normal movement or a normal coordination between the nerve and the muscle, you see the acetylcholine. The acetylcholine is the one that is, round over here. So they should fit in the receptors like normally. Okay. So they should fit in like this. Like how you see this one here. You see where I'm circling right now. They should fit in without any stress. And how this one too is, okay? But look at the other three or the other parts. You have antibodies. So these are the antibodies which are produced by the own immune system that is fighting against us. Okay, so these antibodies, how this whole thing happens is that these antibodies will be produced in the body and they will end up blocking the receptors. So you see how they block the receptors. Okay, so they block the receptors in a way that this acetylcholine cannot go where they have to go. Okay, because if the space is already occupied by antibodies, the acetylcholine cannot come and sit in for a normal coordination. Okay, so this is just to help you understand what is happening. Okay, in myasthenia gravis as an autoimmune disease. So the antibodies, the body will produce the antibodies which will fight against your body to make all these side effects or all these signs and symptoms you are seeing happening. Okay, to okay. Do you understand the diagram right now?
That's fair.
Okay. Now, overview of myasthenia gravis. So we know what is happening now. Remember, I told you we should be able to differentiate between um, Parkinson's and Alzheimer, then myasthenia gravis. We've been able to look out for what myasthenia, we've been able to look out for Alzheimer's disease already and Parkinson's disease already. Myasthenia gravis, so we are looking at it. So I want us to compare myasthenia gravis now with Alzheimer's disease. Okay. With what is happening in myasthenia gravis, you are having what low concentration of what acetylcholine 2, right? With Alzheimer's disease, what is happening? You have acetylcholine being less, okay, and you are giving medications that will help prevent the distraction of acetylcholine, thereby increase acetylcholine in the body. That is what's happening. Sorry, in the brain. That is what's happening in Alzheimer's disease. So I want you to understand that what is happening in Alzheimer's disease is more in the brain. It's similar thing happening in myasthenia gravis, but in myasthenia gravis, it's happening in neuromuscular junctions, not necessarily in the brain. Okay, it is not necessarily in the brain. Okay, so it affects the muscles mostly.
Can you repeat what you said? You said the myasthenia gravis. What is happening? The neuro.
Okay.
Okay.
So
Just
what you are saying
repeat
is that,
what you said.
Mhm.
I get the
Okay,
concept, but you said something right now.
okay. So what we are saying is that, sorry. So what we are saying is that, with what is happening in Alzheimer's disease. Okay, sorry, I was distracted. With what is happening in myasthenia, sorry, in Alzheimer's disease, it is almost similar thing happening in myasthenia gravis. Okay, because look at what is happening in Alzheimer's disease. You have low acetylcholine, and it's the same thing also happening in what in myasthenia gravis. Okay, it's the same thing happening in myasthenia gravis, but the difference in the whole thing is that with Alzheimer's disease, it is happening within the brain, but in myasthenia gravis, it is happening at what neuromuscular junction. Diana, hey, that's fine. Okay,
So please, I get it. I get it. Thank
so
you.
do you understand it now? Yes. So it is
Yes.
the same thing happening in myasthenia gravis, but myasthenia gravis it's happening at neuromuscular junction, and
In
in
the
Alzheimer's disease it's happening in the brain.
brain. Yeah.
Okay,
Okay.
so in both of them, in both myasthenia gravis and in Alzheimer's disease, you have low acetylcholine,
Okay.
but but with Alzheimer's disease, the low acetylcholine is happening in the brain. Okay, and with myasthenia gravis, the low acetylcholine is happening in the muscle.
Okay. Okay. I get it.
All right. Any question about that? I'm trying to make it simple so that we can connect them. Okay. All right.
So, yes, please, I have a question. Please,
Mm-hmm.
this one, is it also a progressive degenerative disease or is acute disease?
Yeah. So autoimmune diseases too, they are progressive. Like
Okay.
like autoimmune disease is like should I say even progressive? It's not something that you well, it's very dicey though, but I don't want to use the word progressive. I don't want to use the word progressive when the brain is not part, but well, I want to choose my words very well. But it can worsen. Let me use the word worsen. Okay, symptoms can worsen. Okay, symptoms can worsen. So most of the times when it comes to brain functions, okay, if you are supposed to compare the two, most of the time brain function in in myasthenia gravis are likely to be a bit, not even fully, if not fully, at least a bit intact compared to Alzheimer. Okay, but we'll look at that later. All right. Let us understand what myasthenia gravis is. Then after we shall bring up some comparisons. Okay. All right. Now let's look at over here. We are saying that you have what you have acetylcholine decreasing at neuromuscular junction. That's what's happening here. Okay, and it affects the eyes, causing ptosis. So this thing you see is called ptosis. Okay, the eye drooping. Okay, it's called ptosis. All right. And you can have your face and speech expression being what affected. Okay. can have it been affected. Then the next one, you can have swallowing issues, respiratory muscle issues. Okay, so when it comes to myasthenia gravis, because it's a neuromuscular issue, okay, issue with the neuromuscular junction, your breathing is what, or let's say respiration is the most concerned part of it. So um when you get any question on myasthenia gravis and they are asking you which one is the priority, please always choose respiration. Even though you have muscle weakness and everything going on, but please, respiration, myasthenia gravis, no matter what's happening, your main concern should be what? Your respiration. Okay. All right. Now, common medications that are used. Okay. Common medications that are used to treat myasthenia gravis. We have the pyridostigmine. Please, this is our first choice, our first line choice of drug. So always take note. Okay. We have neostigmine. We have hydrophonium and ambinonium. Okay. But pyridostigmine is our first line choice of drug used to treat what? Myasthenia gravis. So these are the drugs. And these drugs we are talking about, they are all what? Anti so this is another thing. Remember when we were doing Alzheimer's disease, we said cholinesterase inhibitors. So my question now, so you see why I was trying to draw your attention to that. So my question now is, what is the difference between cholinesterase inhibitors and please, these drugs you see, they are anticholinesterase drugs, okay? They are anticholinesterase drugs. All these things you see. So the examples of anticholinesterase drugs is what you see here on the left-hand side. So now my question is, what's the difference between anticholinesterase and cholinesterase inhibitors?
But there's no difference. It's the inhibitor that they've put at the back now, and it's now anti. So
Yeah,
it's the
Good,
same drug.
it's the same
good,
drug.
good, 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 good. You are getting the concept, and I'm happy about that. So when you see it, like how I break it down, okay, like how I made it easy with the breaking down of the parts, at least you should be able to understand. Okay, the first one was cholinesterase inhibitors. This is this for this one, there's no inhibitors, there is anticholinesterase. So it means they are the same thing. Okay. But do you know, okay, let me ask you this before I I I even say it outright. If they are the same, can you use these drugs to treat Alzheimer's disease?
No,
If yes,
No,
No,
why? If
no.
no, why?
no,
No,
Because
you
these ones
can't.
are for muscles.
the
And the
This
other
azima
one
one
is
is
works on
separate.
the
Yeah,
muscles
ati
and
tí
the
ọmọdé
other
máa ń
ones
lọ́wọ́
works
coffee.
on the brain.
One by one, please. If you want to answer, raise up your
Ɛna
hand.
me pɛ
Sir,
Raise
sɛ
up
answer
your
please,
kwan
I'm
no ma me.
ready. Sir, please,
But
I'm
A
yeah,
me
ready.
mpoɔ
raise
saa
up
Please,
your
tete
I'm
yi mu
the
saa.
ready.
okay,
azima is
Ɛnyɛ
in
Pearl.
the
nyame,
brain, and
ɛnyɛ
Pearl,
this
nyame
one
Pearl's
is in
ɛna
the muscles.
ɛnyɛ nyame na
Oh,
ɛho boa me.
Saki.
Ɛna
Pearl's hand
sɛdeɛ
is up. Pearl's hand is
Okay.
up. Let us listen to Pearl. Okay.
So, thank you. So, if I'm following this lecture very well, you stated that the Alzheimer, the acetylcholine is the low acetylcholine is in the brain, right?
Mm-hmm.
And with this myasthenia gravis, it is happening in the muscles. So the
Mm-hmm.
brain is different from muscles. That's what I
Oh my.
understand about.
Okay, so yes, so
Yeah.
you can't use this, even though anticholinesterase drugs and
Mm-hmm.
cholinesterase inhibitors, they are the same class of drugs, okay? But because of how they are functioning, you can't use these ones in solving problems of what Alzheimer's disease. I'm glad we've all figured that out. Good. We are all good. Thank you. Any other question or any other contribution anyone wants to make?
Yeah, please. Hello, boss. Please, my network was disturbing. I couldn't hear the answer.
Sister, please, can you repeat yourself again?
Hello, Mr. Precious. Can you hear me? Mr. Precious, I want to know if you can
Yes,
hear me
yes,
before I
I
start.
can hear you now.
Okay, so what I understand is the asthma disease, right? Low acetylcholine is low in the brain, right? The acetylcholine is low in the brain. So all the drugs are working in the brain. But the myasthenia gravis, it is we say something that it is happening in the neuromuscular junction. So it is always on the low acetylcholine is in the muscles. So brain is different from muscles. That's why we have different type of anticholinergic acetylcholine medication. Please, do you get it?
It's okay. Thank you. Thank you so much.
You're welcome.
Mm-hmm. Yes, yes. Thank you for that contribution. So any other contribution or any other question? All right, so just to let you know, okay. So let's look at how this one to work. It inhibits the breakdown of acetylcholine, okay? At what? Neuromuscular junction, thereby increasing what? Acetylcholine at neuromuscular junction. You know, the other one was in the brain with Alzheimer's disease. This one is what? At neuromuscular junction. It's even here, okay? And when acetylcholine is improved at neuromuscular junction, you now have what? An improvement in muscle strength. So that's how come you overcome myasthenia gravis. Okay. So when you do this, problem solved. And remember I said pyridostigmine, those of you who
It's
have
the
given this
first
drug before in real
choice.
life case scenarios, you'll see. Yeah. And I mean, as soon as it means expected, that's our first choice. Okay, so these drugs, have it in mind that they increase acetylcholine at neuromuscular junction, okay, to improve movement. All right. Okay, so if that is so, let me ask you a tricky question. Can you give any of these drugs in Parkinson's disease? If yes, why? If no, why?
Okay, you can't give Parkinson's because Parkinson's disease, they need acetylcholine. You don't want to give them anything that will reduce the acetylcholine, and these drugs will do that. So,
Are you sure?
yes, I'm sure.
Come again with what you said. Maybe I didn't hear you well. Hmm?
In Parkinson's, the
Hmm?
acetylcholine is low.
It's
Are you
high.
sure?
It's
High.
high. Yeah, in Parkinson's, the acetylcholine is high, and we want it to come down.
Uh-huh.
So if you give these drugs makes acetylcholine go up.
Higher.
So if you
So
are
you don't
giving it,
want that. Yes.
yes, we don't want that.
Yes. So you don't want any drug, whether in the brain or in the muscles. You don't want any drug increasing
Mm-hmm.
acetylcholine in Parkinson's disease. So you're not going to give it. All right. Good.
Yeah.
Good. Are you trying to connect all of them right now?
Yes.
Okay.
Yes.
Let's see what we have here. So just to let you know, we'll continue from here tomorrow, God willing. Okay. Just to let you know that we use, you see, for all autoimmune. So I think the person who was asking the question, whether myasthenia gravis is what do you say, like degenerative disease? Please, you can't classify it as degenerative disease. I think the main classification is autoimmune disease, which is also its own classification. Okay, so autoimmune disease, um, degenerative disease, new degenerative disease. So they are different classifications. Okay, just to let you know, the person was asking. Then I wanted to draw your attention to something. Oh, I'm almost forgetting. Let me see if I can remember. Yeah. Before I even say that, who can give me other examples? We have lots of autoimmune disease around. Even cystic fibrosis is autoimmune disease. We have lots of autoimmune disease, plenty of them. Okay. Who can tell me?
Lupus,
Yeah, lupus.
rheumatoid arthritis.
Like we have lots of
Guillain-Barré
them.
syndrome.
Oh, what's
Guillain-Barré
Who
inside
can?
syndrome.
there? Oh,
Yeah. I want to ask a question. Who can tell me what he or she has seen when it comes to treatment of autoimmune disease? In terms of the medications that are used to treat autoimmune disease, what have you what have you realized? We give them steroid. Are you aware?
Me, I've realized that.
Most of them. Okay. So as part of your tricks in learning, okay, when you get a condition and it's autoimmune disease, and you are not even, let's say you've not studied it before, you are not sure whether the treatment modalities are this or that, at least you should know that steroid is mainly used as part of what's treating autoimmune disease. Steroid is used to bring your immune system down. Okay, it's used to lower your immune system a bit. So when you lower, sorry, when your immune system is being lowered a bit, it looks like your immune system will slow down the attack on your own body. Okay, it will suppress that effect happening and will help improve things. So with myasthenia gravis being an autoimmune disease, apart from pyridostigmine, that is being our first choice of drug used, we also add drugs like steroid, okay, as additional therapy. All right. So I think we should end it here. And if God permits, tomorrow we can come and continue. So yesterday, I also mentioned that when it comes to autoimmune diseases, right, no matter what is used to treat, normally you will see steroid therapy also being added. Okay, you'll see corticosteroid being added to treat autoimmune diseases. Autoimmune diseases, know how they come about. You have the immune system attacking its own cell, attacking your own body, right? So you take these immunosuppressants or these steroids, then they suppress the immune system so that you have that action being tamed, okay? So that your immune system will be lowered a bit, in the sense that it can't fight against your own body or itself. So that is it. So when you get myasthenia gravis anywhere, apart from the drugs which are being used to treat, like what's the first line of medication that is used to treat myasthenia gravis? Who can say that quickly?
Pyridostigmine.
Just say Gemini.
Paralostomie.
Hey, okay, so all right. So I have been pronouncing this smoothly. Some people are jumping over rams. Pyridostigmine. Okay, that's right. Okay, so that's our first line of drugs. Okay, to treat it. Don't forget this. You see how we've made it simple. Don't forget these things we are studying here. All right. So that is it, and it is used when symptoms worsen and acetylcholine inhibitors are insufficient. So, this additional therapy like the steroid, they add up and, they help to treat these autoimmune conditions. Now let's look at administration considerations. So you give before meals, okay? And when you give them, so look at this point. This point, you can get good questions from this point alone. So understand what this point is trying to say. You give before meals. So when they give you an instance where a client or a patient who has myasthenia gravis is about to be fed, no matter how the question is being framed or whichever tricky way they want to take you through, please know that they have to take the medication before they eat so that the there will be improvement in swallowing. Okay, so that the patient can be able to eat well, chew well, and swallow well. So that's what this point is trying to make. Remember, acetylcholine is less at the neuromuscular junction, right? So just imagine the ptosis. You can just picture the ptosis in your mind. Look at this one. Okay, look at this picture here. So the muscles are weak all over. All right. So it is all, and it also makes sense, right, to give the medication to strengthen the muscle before you even feed, which will help in the swallowing and all of that. Okay. All right. And you have to administer it on time too. You administer on time. And when you administer on time, it prevents muscle weakness. Delayed doses will make it difficult for the patient to eat or to swallow. That's if you delay the dose. This is even delaying the dose. So don't even think about missing doses. Okay. All right. If you have any question on this slide, you can ask. If not, let's look at something here. So we have something we call hydrophonium test or tensilin test. So this hydrophonium is the same, it's an example of these drugs which are used to treat myasthenia gravis we talked about. Okay, remember, it's not any special test. Okay, it's we are just using the drug to perform something. We'll talk about it right now. So hydrophonium test. So it's another name for hydrophonium is tensilin. Okay. So what is tensilin test or hydrophonium test? It is used for the diagnosis of myasthenia gravis. It helps us to diagnose it, and according to contemporary research, it looks like it's even old-fashioned. Okay, it looks like it's old-fashioned. Now they use some tests they call I found something. Is it ice pack test? Who has seen that before? Ice pack test. Okay, so just I'm mentioning it here so that when you see it somewhere, okay, we have something we call ice pack test. Let me talk about what we have here. Then after I'll say something small about that one. It's very easy. Anyway. So it is used for the diagnosis of myasthenia gravis. This is what happens when you give the medication, okay, to someone who is suspicious, or let's say who's suspected of having the condition. You will see muscle strength. It's IV, okay? You give it IV intravenously. The dosage, I can't say it. I think is it 2 and 8 milligrams or something. So you give it IV. Then after you give it, within 30 to 60 seconds, you will see improvement in the muscles of the person who is being affected. Okay. So if let's say there is ptosis or there is drooping of the eyelid or something, as soon as you give it, within 30 to 60 seconds, you see strength in that part which is drooling or sagging. you see strength. Okay, you see it improving, and the effect will last for about 4 to 5 minutes. So that is all. If you hear about tensilin test or hydrophonium test, that's all about it. Okay, and that means you have a positive test for it. Okay, a positive test for it. And with a negative test, when you give it, you rather see symptoms worsening or there will be no improvement. Let me try and this one sounds tricky, but it's not that tricky. Okay, look at this. My senior crisis. You see, in my senior crisis, you have acetylcholine very low at your muscular junction, and you have muscle weakness. Okay, so you're going down. All right, that's my senior crisis, right? Cholinergic crisis, you have symptoms worsening. Okay, you have symptoms worsening. It's like you have more of, you know what cholinergics do, right? Cholinergics, how should I even say? Remember, anticholinergics reduce secretions. So cholinergics will rather what cause secretions. Okay. So think about whichever secretions can we even give as an example, like lacrimation. That's increase the increment of tears. Okay, you sweat,
Elevation.
salivation. Good. So cholinergic effect will give you like all those things. It will give you diarrhea. You see, anything that has something to do with like liquid flow. Okay, that's cholinergic. Okay, that's cholinergic crisis. That is why in cholinergic crisis you give anticholinergics like atropine. Okay, you give because that's the only thing. That's one of those things that can um, reverse cholinergic crisis. Right. So um, with the hydrophonium, which is an example, like it increases acetylcholine at neuromuscular junction, right? So when you give it and it is too much, okay, it is too much at the junction, you're going to have what cholinergic crisis. Like you're going to have a lot of like you're going to have the symptoms worsening, or there will be no improvement. Okay, I have I have something to show you here at the next page. Let us talk about the contraindication, then I will show you on the next page. Okay. Because because hydrophonium, right? Because hydrophonium increases acetylcholine, you don't want to give it in people who already have bowel obstruction because it's going to make the obstruction worse. Okay. Remember, even if there is no obstruction, even in a normal gut, it causes constipation, right? You remember that yes, let me leave it that way. Okay, it causes constipation and all of those things. So it's going to make obstruction, bowel obstruction worse. It's going to make urinary tract obstruction too worse. Okay, and it's going to affect GI motility. Okay, so it's like it stiffens everything, doesn't permit the smooth flow of it. So it's contraindicated in especially these three areas that we've mentioned here. Let me show you what I have on the next page, maybe to help. Oh, not this one. I think this is what I was trying to say. So let me come here, then after I'll go back. Okay. Let me come here. So I want us to look at the differences between myasthenia crisis and cholinergic crisis. With myasthenia or with myasthenic crisis or myasthenia crisis, okay, you have under medication, all right, under medication because remember myasthenia gravis, just remember myasthenia gravis, you have low acetylcholine, okay, at the neuromuscular junction, and everything is coming down. So myasthenia crisis is caused by the under medication of the drug, okay. I want to find simple ways to explain this. Let me take this one again. In myasthenic or myasthenia gravis or myasthenic crisis, you have everything coming down, right? The person is already drooping, ptosis, there's muscle weakness. And there's muscle weakness because the medication that increases acetylcholine at the neuromuscular junction is low. So that is what we mean by the under medication here. Okay. Cholinergic crisis. Remember, cholinergics increase acetylcholine, right? So when you have cholinergic crisis, it means you have more of the medication that increases what? The acetylcholine at the neuromuscular junction. That's why you're having cholinergic crisis. So myasthenic crisis is under medication. It's caused by under medication of the drug. And cholinergic crisis is caused by what? Over medication of the drug. So with regards to the hydrophonium that we were talking about, because there's already remember hydrophonium increases what? Acetylcholine at the neuromuscular junction, right? So because myasthenia crisis, you have under medication. That means you have low amounts of acetylcholine muscular junction. When you give this medication, you are going to see improvement. Okay, the weaknesses you see in myasthenia crisis is going to be improved because you are introducing what? Acetylcholine at the neuromuscular junction. Okay, now look at cholinergic crisis. Cholinergic crisis, you already have more of the acetylcholine already there. Okay, so when you give more of the acetylcholine, you weaken, you worsen the whole situation. So you see weakness worsening most of the times. Okay, so normally you see the weakness worsening or you see no change at all. Okay, and this is the timing. Most of the time the weakness will occur in less than 1 hour after the dose. Okay, that is for overdose. So this one is, I think, for the cholinergic crisis, and for the weakness, which is so this one, the first one is yes, cholinergic crisis, and this one is myasthenic crisis. The weakness happens after 3 hours. Okay, 3 hours after the dose, you'll see weakness.
Please, I have a question.
All right.
I have a
Okay.
question. Please, the hydrophonium, is it the diagnostic test or a medication? Because if I am following
So it's a medication, and we use it to do a diagnostic test too.
Okay.
The hydrophonium itself is a medication, yes, and it is used to also perform the test.
Okay, I get it. Okay.
Yes. So that's why I was explaining that during the test, you just give it to the patient like IV. Okay, and this is how you see if it's positive. You see muscle strength improving within 30 seconds to 60 seconds. And you will see the improvement lasting for 4 to 5 minutes.
Okay.
Okay, so you use the medication to do the test.
Okay, sir. Thank you.
But yeah,
Do you get it? Yes, sister.
the contraindications at the right side is for the drug, right?
Yes, it's for the drug.
I'm confused because this drug is like the contraindications are looking like contraindications for anticholinergic drugs, but this one is a cholinergic, right?
Yeah.
So I'm confused.
Or maybe I'm not. Wait. Maybe I'm not
Yes,
getting your
I know
question. Come again with your question.
the anticholinergics, the atropines, and those drugs. These are the contraindications.
Mhm.
The bowel obstruction, urinary tract obstruction, and all that too. But I'm confused that this is also contraindicated in this drug too.
Okay. Let me try and see if I can explain. Okay. Um, what does so hydrophonium? Let me use hydrophonium as an example. Hydrophonium is anticholinesterase agent, right? Which means that it increases what?
Acetylcholine.
Acetylcholine. Okay.
Yeah.
And the cholinergics that you mentioned also what increases acetylcholine, right?
Yes.
So in other words, they all have the same what contraindications because they are all moving in the same direction.
Okay.
Should,
Yes.
should I take it again or you understand?
Take it again, please.
Okay, so let me take it again. Hydrophonium and those pyridostigmine and all of those medications, okay, that we used to treat myasthenia gravis, we
Yes.
know they are what? Anticholinesterase agents. So anticholinesterase means what? A drug that is preventing what? The degradation of acetylcholine, right? So in other
Yes.
words, it will increase what? Acetylcholine at the neuromuscular junction, isn't it?
Yes.
Good. And when you talk about pure cholinergics, what does pure cholinergics also do? They will also increase what? Acetylcholine,
Yes.
right? So it means that
Yes.
they will all have, because they are all moving in the same direction, they will all have the same contraindication.
Yes. I
Do
get
you
it.
understand it? Okay.
Yes, I get it. Thank you. Then
Yeah.
anticholinergics too that reduce acetylcholine too. The contraindications are, or I'm mixing it up. The contraindications are also bowel obstruction and this GI motility issues. I don't know if that's correct. Like they asked us not to
Um.
give atropine in patients with bowel obstruction and those things.
Yes. So. Yes. I think that one too is true. But I think it's a different pathway. Okay. I don't
Okay.
want us to. Yes, it's a different pathway. I don't want us to go there right now. Anticholinergics. When you remember, so this one, let me use the popular thing that I normally say. I can't prove, right? I
Yes,
can't prove, which means you have constipation, right? I
yes.
can't, I can't pee. That's urinary retention.
Mm-hmm.
I can't cry. That is, I mean, so let me use the poo and the pee to even,
Drew.
um, yes. So that is like constipation and what urinary retention. So because of the effect of anticholinergics too, causing constipation
Mm,
and what was it? Causing urinary retention too. You know, urinary retention is different from urinary tract obstruction, right? And
yes.
constipation is also different from bowel obstruction. Okay.
Okay.
So I think they
Okay.
have different pathways. Yeah, so it doesn't make
Oh,
sense to give yeah, so it doesn't make I think there are different pathways, yeah. Let us leave it
okay.
that way. Otherwise, when you try
Okay.
to overthink the pathways, if you don't know the exact receptors and those things, you mix them up. So let us keep them exactly as they are, okay, and move
All
on.
right.
Otherwise, Yeah, otherwise it will be plenty. I think
Mm.
already it's already plenty in some people's mind, right? Right now.
So please, I'm confused on one thing here. When you come to the left
Okay.
side, you said muscle
Okay.
strength. The muscle strength improves within 30 to 60 seconds. Effect lasts
Yes.
for 4 to 5 minutes. So I'm confused that after the effect, after 4 to 5 minutes, the muscle will be weakened again. Or what? I'm not.
Yes. Yes. Like it will not stay forever. After some time. So it has a short duration. Okay. Like it's short acting.
Okay. Okay. Thank you.
Yeah. So the effect of the medication will come down. That is
Okay.
why we have this here. So you see, it's not a condition that you can cure. Okay, look at this part. Where is it? Where did we even talk about this? Yeah, look at this one, the administration consideration. Give before meals. You see why we said this one? So
Okay.
it means you give it to help improve muscle strength. Then after it will, I mean, if the person finish eating, the person definitely like slowly goes back to his or her normal state. So it doesn't stay forever.
Okay. Thank you.
Yes, you are welcome. Any other question?
Yes,
Okay.
please.
Yes, I have a question in the chat box, please.
You can read it for me, okay? I can't. You can say your question here. Sorry, I
Okay,
can't. Uh-huh.
that's fine. I'm asking, it's just part of the management for myasthenia gravis. If a
Okay.
patient is already drooling in the myasthenia gravis, what is more advised? Are we allowed to suction or just manage with positional changes, like positional drainage of the secretions?
Good. Good. It's a very nice question. So I it came across my research. What do you give? Um, Wait. Let's look at something. What's the name of this drug? What is a drug? What is a drug that is used to reduce secretions? Like
Atropine.
come again. I want the class.
Atropine.
I want the class. I want the class. I want to make a point here.
Is it the glycopyridine?
Good. Glycopyrrolate. Atropine too can be used. Okay.
Okay.
Yeah.
Yeah. So my question is. So let me ask you a question. On this one before I continue. Can glycopyrrolate be used to control secretions in, or let's say drooling in myasthenia gravis?
It's an
Mm-hmm.
anticholinergic,
Who can answer
right?
that? So it's an anticholinergic, right? And
Yes.
already in myasthenia gravis, you have what? Acetylcholine being low.
So yes. So if
So
you
I'm
give,
asking, when you give, you do what?
you worsen the case for the patient. Oh,
You worsen the case for the patient. Okay. All right. So what about atropine? Can atropine be used?
Atropine can be used in cholinergic crisis where there is so much secretions.
Okay. So you see how tricky. Thank you for bringing that up. Okay. I was doing lots of researches before I came across this. So generally, anticholinergics are generally contraindicated in what? In myasthenia gravis. When you want to control secretions, okay, like drooling in myasthenia gravis, studies show that it is allowed to use atropine. You can never use glycopyrrolate. Even though glycopyrrolate and atropine, they are all in the same class, anticholinergics, right? So I was trying to figure out like why is it that they are all anticholinergics and they all reduce acetylcholine at neuromuscular junction, but you can use one, but you can't use the other? So I think it's all because of the mechanism of action. But just to let you know, atropine can be used. Okay, even though it's anticholinergic, I think that is the only drug or something that stands out. But please, pyridostigmine. I said pyridostigmine. Glycopyrrolate. Please, glycopyrrolate. You can never use in myasthenia gravis. It is a 100% contraindication. So, Jovita, the answer to your question is you can use atropine, which is an anticholinergic, but you can't use glycopyrrolate, which is also an anticholinergic, even though they all control drooling.
Okay, but my question is, because it's a question that I've seen. The question is, can we suction, like suctioning, oral suction,
Oh yeah,
or
you
can
can
we use
suction. You can
posterior
suction.
drainage? Because the question was how to manage the draining. Should you just reposition the patient so that they would drain by themselves, or do you suction them? There were like two options to choose one.
Okay, so one thing is the position is one. Okay, position is first before suction. That's what I think, because the drooling is continuous, right?
Yes.
The drooling is continuous, so the suction comes in. You can't do continuous suctioning. It will even irritate mucosal membrane. Okay, so
Okay.
so the main thing is you position the patient like sideways so that the person will not choke on secretions. Okay, then if secretions are more, you can then suction. So when it comes to, prioritization between the two, I would choose positioning before suction. That is what I would choose.
Okay, thank you.
I saw so
Yes,
same
yeah.
question, but the answer was assess the airway first.
Okay. Yeah. So and remember, I told you yesterday that when the priority action, when it comes to myasthenia gravis, is what? Respiratory. Okay. So if you see myasthenia gravis and you see maybe what will be the priority action and you see anything like respiratory or prepare for mechanical ventilation, please, normally they are likely to be the answers. Okay. So anything airway, respiration, they take the priority. All right. Any other question or we can carry on?
Boss,
So,
can you make some clarification for me? I have some question.
okay.
Please, can you go back to the table you did the comparison between myasthenia gravis and then cholinergic? Yes. So I want to know, does the cholinergic crisis and myasthenia crisis have the same symptoms? That's one part of the question. And then another question is with the Parkinson disease, you said it's as a result of higher levels of choline. So the cholinergic crisis too, it is as a result of high level of the choline. So I want to know, will they have, how will you, contrast them?
Please. Okay, I thought I was muted. Your second question, I didn't get your first. Okay, let me answer your first question, then you can repeat your second question. Okay, second question, I didn't get it well. So, with your first question, you want to know whether they are the same, right?
Yeah, the
My
signs
senior
and
is the same, right?
symptoms.
Okay,
No,
so
not the same. I know maternal crisis, there is under production of the choline. And then the cholinergic crisis, there is overproduction. So I want to know, so when it comes to signs and symptoms, will they
the signs and symptoms?
be
They are
different or
different. They are different.
Okay.
Yes, they are very different. So, just imagine. Wait, let me see. Hold on.
So I am asking that question
You
because
see,
like the chromium is done sometimes to distinguish between myasthenia crisis or the
cholinergic crisis,
cholinergic.
yes. Yes,
Yes.
so
So if they are different, if the signs and symptoms are different, then do we need to do that test to be able to distinguish between them?
wait with your second question again. Let me answer this one, then I'm trying to connect something, and I don't want to forget what I want to say. So I'm trying to connect things.
Okay.
You see, when it comes to this one, myasthenia crisis, cholinergic crisis, I want you to understand it this way. Just you forget. You see, when we say crisis, it means you have the worst form of something happening. Okay, so
Yes.
when you hear of myasthenia gravis, what comes into your mind? Okay, you see all those signs and symptoms you talked about. Ptosis,
Yes,
muscle
please.
weakness, facial drooping. You see all those things. So they worsen.
Yes.
Okay. All right. When you hear of cholinergic crisis, you know cholinergic crisis increases secretions, right? So
Yes,
what comes
please.
into your mind? I think we have a popular I have it ahead somewhere. I don't know whether it's part of. Have you seen this word before? Sledge.
Yes.
Okay.
Salivation,
Yes, we have
lacrimation,
Yeah.
sledge. Okay. It's a very popular acronym.
Okay.
Salivation,
Lactation.
um, lacrimation, urination. What's the D? D is defecation, right?
Diarrhea,
Yeah,
yeah.
it's like you have
Yes.
diarrhea.
Diarrhea.
Okay,
Diarrhea.
diarrhea or defecation. Yes.
Diarrhea.
Yeah.
This one is GI.
Cramps.
Like
Yeah, cramps.
it's like gastric. Or what I say gastric, like GI distress, something
Yeah.
like that. And E is emesis, vomiting. So you
Yeah.
see, all of these things. Sludge itself is like a sewage. Like how can I even give an example of a sludge? Like a very soft form of like semi-solid sewage. Okay, it's like watery sewage from factories. When you hear of the word sludge is actually a word. Okay, so because sludge is like watery paste form, it mimics that. Okay, so everything over here is like watery. So look at the first one, which is salivation. It's watery, something to do with water. Lacrimation, something to do with water. Urination, it has something to do with water. So you see, all of these things have something to do with water. That's why, I mean, the one who coined this even chose the word sludge. Because sludge is something like water, like it's like a paste form of, or like semi-solid form of sewage. Okay. So this one can help you. This one is a perfect. If you are supposed to, how many letter words? Let me see. 1, 2, 3, 4, 5, 6. If you ask to state 6 side effects or signs and symptoms of cholinergic crisis or effect, you can remember sludge. You state all of them. So that's what happens. Okay. And the
Okay, sir.
myasthenia crisis is what it's all about. You have the load, I mean, muscle weakness and all of that. Please, have you understood that part?
Yes, please. Okay, so the second
The
part
first part
is
of your question, have you been answered?
yeah, the first part.
And then you
Yes,
can continue with
please.
your second. Hello.
Yes, the first part. Yes, I can
I'm
hear you.
listening
The
to
first part
the,
is answered.
yeah. So I'm listening to the second part. Yeah.
So the second part, the other lecture we had on the Parkinsonism, we made mention that it is as a result of high level of the acetylcholines.
Yes. Hello.
Hello, sir. Please, we can't hear you.
high level
okay.
of
I thought you.
acetylcholine.
I
So I was
I thought it
like,
was. Oh, sorry. Then your line was breaking. Oh,
Yeah,
was
we
it
can't.
was it from my line or from his line?
I think it's from him. We can't hear him.
Because it keeps on breaking. Like I hear part, I don't hear part. Yeah. So
oh, sorry. Should I come again?
I didn't even check the name. My brother was speaking. Yes, about the second part. You said Parkinson's disease is caused by it happens when you have higher amount of acetylcholine. Yes, and that is true. And I didn't hear the last part again. So you can come again over there.
Okay, the last part is also about the cholinergic crisis, where we also have high level of acetylcholine. So how do you contrast the two so that you will not get, I mean, when it comes to the science center, you won't be, because I'm looking at all acetylcholine being high. So at what instance
Okay.
will you, this high level of acetylcholine is associated with Parkinson?
Okay.
And at this point, it is related to.
I don't know. I don't know if I get you well, but I think I have your answer ahead. Okay. All that you want to ask is that you want to know how acetylcholine is reflected among all what you've talked about, from Parkinson's disease up to myasthenia gravis, isn't it? What happens there and all of that. I think I have a nice diagram for you. Let us talk about this, then after I'll show it to you. Okay, so that it will wrap up everything nicely. So hold on, okay? Jacob,
All right, thank
I'll
you.
show it to you very soon, yeah, so that you see all the differences. I brought it here.
All right.
Okay. Do you have any question right now? Okay. I think we can carry on. So with cholinergic effect, we have increase at so we thought about it. Okay, just remember sledge. You see all of these things in it. Okay. So this is what you see in cholinergic effect. That is when you have overdose of the medication. Okay, it gives you cholinergic effect because it increases acetylcholine at the neuromuscular junction. That is why it gives you what cholinergic effect. So these are what you see as cholinergic effects. Okay. And please, if you are coming to do this stencilling test or hydrophonium test, please make sure your antidote is available. Remember, hydrophonium increases what? Acetylcholine at neuromuscular junction. And this is anticholinergic, atropine. So anticholinergic means it can reverse the action of what? Cholinergics. In other words, it can reverse the action of what? Acetylcholine. Okay, so make sure you have atropine ready so that just in case you can use it. Okay. All right. Then the next one is keep resuscitation equipment ready. Sorry, monitor respiratory status, which is a priority. Remember, you see this one, it's a priority because you're airway first. I've already told you this when it comes to my senior babies. All right, then this one, keep resuscitation equipment ready so that you can be able to use it when patient is not showing up. Assess muscle strength, swallowing ability, speech changes, and doses. Okay. All right. So we've talked about this too already. Let's look at nursing management or nursing monitoring. What we have to monitor for. We have to monitor for all vital signs. They are very necessary. Reflexes and gait. Watch out for respiratory distress. Remember, respiratory. Difficulty swallowing too is there. Okay. Client teaching. Take medication exactly on schedule. Do not miss your dose. Do not skip. dose. Okay. All right. Do not increase or decrease dose independently. It should always be advised by the healthcare provider. Always make sure you report sweating, nausea and vomiting, twitching when you are taking the medication. Medication does not cure myasthenia gravis. It only relieves symptoms. So you see, we are not giving all these medications to cure. We are just relieving symptoms so that you can carry on with your day-to-day activities. Okay. All right. Now look on our left-hand side here. I prepared something nice for you, and I think we have similar things on our right-hand side here. So, English key point, even if you forget about anything on myasthenia gravis, don't forget that pyridoxine is your first line treatment, okay, which increases what? Acetylcholine at muscular junction. You give before meals. We've explained that why we should do it, right? Hydrophonium test differentiates crisis. So if you want to know whether what is happening is myasthenia crisis or cholinergic crisis or something else, you can use hydrophonium. You can use hydrophonium to differentiate. Okay, that's hydrophonium test. All right. Before that, make sure your atropine is ready so that you can give full overdose. Respiratory failure is a priority concern. Do not miss doses. Memory trick here. Muscles gone weak. I mean, that's how some people will call it. Okay, myasthenia gravis. So your muscles have gone weak, right? You give meds before meals, watch breathing first. Overdose means you have too much what? Acetylcholine, and you have what? Cholinergic crisis.
Sir, please, I have a question. Maybe I didn't
All
hear
right.
you. You said do not mix doses. I don't get.
Yes.
As in, is it the first line medication? We shouldn't mix it with another medication or what?
Yeah, so do not mix doses. Like it's like if maybe it has been scheduled for you to take it at 6, 2, and 10, make sure you don't miss any dose.
Oh, okay, okay. I thought maybe another. Okay. Sorry, I didn't see the word. Thank you.
Yeah, so that's what it means. Okay. Okay. Any other question?
Boss dear,
Yes, sister.
in a priority question, and maybe they are like the nurse has the next 1 hour to do like some 4 um activities, and in one of the question, one of the options they will be like administer this drug. Then maybe there are other ones there. I'm thinking maybe this one should be priority, or it will depend on what the other 3 activities are. Because I've seen a question that was saying administer oral analgesic, and that was not their priority. They were like, you can wait, that one will not cause any harm if you don't give it in the next 1 hour. So I'm thinking, is this drug something that if you don't give, maybe it's scheduled at 2, if you don't give at 2 and you wait till 3, it can harm the patient?
Okay. So the medication is to improve weakness, right? So if you skip doses, it means you not see that improved strength that you want to see. It will not be effective. The medication is only to improve strength, okay, to weak muscles. So if you are missing doses, you are not going to see the improvement. That's what it means.
Okay.
Yes.
Okay, thank you.
You are welcome. Any other question? Okay, let's carry on. I have questions for you if you have any question. So my first one here. Can I get a reader?
A client with myasthenia gravis is prescribed pyridoxine. When should the nurse administer this medication?
Who wants to answer?
Before me. 30 minutes
Answer is
30
B.
minutes before me.
Okay.
I'm trying now.
Okay. Kindly mute up if you are not talking to us, please.
Who is even singing?
Did we get it correct?
Yes, sir.
Okay. Okay. Our next question.
A client with MG develops increased weakness 1 hour after medication administration.
MG is myasthenia gravis. Okay.
Myasthenia gravis. Yeah. I know. What is the priority interpretation? A. Myasthenia crisis. B. Cholinergic crisis. C. Medication effectiveness. And D. Disease progression. The answer is C. Myasthenia crisis.
Are you sure?
Wait, a client.
Why
Yeah.
not B?
No, it's
Yes.
B.
It's B.
It's
B.
B.
Weakness 1 hour after. Okay.
And 3 hours.
After the medication.
So you see that it is
Sergio, your network is breaking.
very easy, but if you
Sergio, please, your network
Yeah.
is breaking.
oh sorry.
The answer
It's
is
B. B.
Do we all agree?
yes.
Yes.
Okay.
Yes.
All right. So our next question.
A client with myasthenia gravis is receiving an anti-cholinergic medication such as pyridoxine. The nurse ensures that an emergency medication is readily available in case of cholinergic toxicity. Which medication should the nurse have available?
C.
Epinephrine, Narozone, atropine, diazepam is C.
Atropine.
Atropine or atropine? Oh, I don't want to know.
Okay.
Atropine.
Okay. Atropine. Atropine. So is pharmacology difficult?
Yes.
No,
No.
If you understand.
it's not.
All right. Our next question.
Fazia, please, my hand is up. Oh.
Oh,
The
sorry, I didn't
previous
see.
question.
Talk to us.
Please, the
This one.
previous, no, the other one, the cholinergic crisis. Yeah, yes,
This
please.
one.
So I want to understand because myself, I was choosing A. Do we have muscle weakness? Do we have weakness in cholinergic crisis? I was thinking that before you select cholinergic crisis, then you should see some of those symptoms that we explained, like the sledge. But here the client developed increased weakness. So I was thinking that it will be myasthenia crisis, meaning that the muscle weakness have increased. Please,
After
please, do you
Okay.
understand my question?
Okay, wait. I understand your question perfectly, but do you know something? Let me answer your question with just one slide here. All of us
Okay.
kindly hold on. Can you see this?
Yes, I can see it.
So look at this one. When you give hydrophonium increases what? Acetylcholine. Okay,
Mm-hmm.
at neuromuscular
Mm-hmm.
junction. In myasthenia crisis, your muscles are already weak. So when you give hydrophonium, your weakness will now improve to become stronger. you get strength in that muscle. Okay, do you understand that part?
Yes, but the
Wait,
question
hold
tell
on,
us
hold
it
on, hold
was
on, hold on, hold
hydrophobium.
on. Let's take it in bits. Okay, do you understand
Okay.
the first point here?
Yes.
Okay, good. Now, in cholinergic crisis, with
Mm-hmm.
regards to this medication, listen to it very well. With regards to this medication, when you give it, okay, when you give it, you are, and if only it is cholinergic crisis happening, you are going to see the weakness worsening or no change. That is what this one does. We are not looking at cholinergic crisis generally. Over here, it was, we are we are linking it to hydrophonia. Okay. If you want to talk about cholinergic crisis, like separately, that is different. But with regards to this medication, this is what it does. Look at the question. Yeah, so this is the question. A client with myasthenia gravis develops weakness 1 hour after medication administration. So let's say even if you don't know the medication that was given, you've studied myasthenia crisis, you've studied cholinergic crisis. You give a medication and patient weakness was increased. What should even come to your mind? Because if it is how do I want to use like layman who can explain it better for you to understand.
You see, but yeah, please, you see that hydropium or what?
Hydrophonium, yeah.
Yeah, that one is a test. But I thought here they are talking about the myasthenia gravis medication itself. Or I'm not getting it.
They did not mention any medication here. They are just giving you a clue that
Okay.
a client with
Okay.
myasthenia gravis, you see, they're not giving, yeah, so they did not give you any clue about whichever medication that was mentioned. Okay. They said they gave a medication and weakness increased 1 hour after giving the medication. So you can't think of whether it's myasthenia gravis medication or even if it is that, I mean, it wasn't mentioned. Let us take it exactly as it is. Okay. And
Okay.
with the characteristic described here, what do you think it's in line with? Is it not cholinergic crisis?
Yes, it's in line with B.
Because, yes. Please, do we all agree?
Yes.
Do we all,
Yes, please.
do we all agree?
Yes.
Yes, please.
Okay.
So, but
Okay,
if
thank you.
so, but make it like I don't know, easier for me to understand. When you serve a drug and after 1 hour or in less than 1 hour, the symptoms becomes worsened. It means it's cholinergic crisis. So a drug has to be administered for you to say that it's cholinergic crisis.
Yeah. Yeah. If they tell you it improved, okay, if they tell you after giving the medication the condition improved, then it means what was happening was what? Myasthenia crisis.
Mm.
Okay, it is what was happening before the medication was given was what? Myasthenia crisis. But if they give and it worsens,
Mm.
it means what was already happening was what? Cholinergic crisis. That's what it means.
Yes, thank you.
Understood?
Yes, sir.
Okay.
Yes, please.
All right.
Thank you.
You are welcome.
Yes, sir.
Anyone to take this one for us? Or any question?
Hello. Hello.
Yes, Hussein.
Yeah, I'm really sorry. My network took me out. I just wanted to screenshot the last two slides before the questions. Then I'll follow up.
Hey, so you are screenshotting my slides.
No. It's because I didn't get it. I was out. I was trying to join, but unfortunately, I
Which part?
couldn't. So I want. I mean, the trick, the memory trick, and okay, I
But you
think
get the
it's
videos, okay? You get the recordings,
okay.
The
so
content will be posted.
Okay, thank
just
you.
in case. Okay, you get the recordings. So please carry on with the question for us. Let's see.
We are done with this one.
Oh, we are done with this one.
Yeah.
Are you sure? Okay.
Yeah, we didn't answer, but we are done with it. And some of us
Oh,
chose.
madam. Yo, let's do this one.
A client with myasthenia gravis is experiencing worsening muscle weakness. The nurse administer itrofonium to help differentiate the cause of the symptoms. First finding would indicate that the client is experiencing a myasthenic crisis. Increased salivation. B. Bradycardia. C. Diarrhea. D. Improved muscle strength after hydrophonium. D. Increased muscle strength.
Are we
Improved
sure?
muscle strength. Yeah, D.
Do you all agree to D?
D.
Okay. All right. So that is true. Okay, our next one.
A client with myasthenia gravis is prescribed an anti-cholesterase medication such as
So you see, I've been doing well, right?
yes, with the mention of the medication
I've been doing
such
very,
as
very well. Continue.
coridostomy. Which instructions
Mhm.
should the nurse identify as most important to include in the client teaching plan? A. Increase protein intake. B. Take medication at bedtime. C. Do not skip doses. Limit food intake. C. Is C.
Anyone with different answer? Or we are all choosing C? If you think different, you can let us know, okay? All right. So when you get questions around these areas, whether similar or, equal to this question, you should not miss this. These are like bonuses, right? And you should not forget them. Okay, the next one. I think this will be the last but one also.
A client with myasthenia gravis is prescribed an anticholesterol medication such as coridostomy. The nurse monitors for expected adverse effects related to this therapy. Which findings should the nurse anticipate? A. Dry mouth. B. Constipation. C. Excessive salivation. D. Urinary retention. This one.
Mm-hmm.
Sister Beatrice, answer it and let's follow you.
This one, all of us will answer.
This one, all of us will answer.
Okay.
Yes.
It's excessive salivation.
C.
It's C.
Excessive salivation. Do you all agree?
Yes.
Excessive
Yes.
salivation. That's the answer. Okay. All right. So this is our rationale, okay? So you see the sledge we were talking about, salivation. This is the sledge, okay? Yeah. So just keep this one as your acronym for cholinergic effect. Okay.
Okay.
All right. The next one.
A client with myasthenia gravis who is receiving anticholinergic therapy develops new symptoms. The nurse suspects a cholinergic crisis. Which assessment finding support this suspicion? A. Dry mouth. B. Diarrhea and sweating. C. Tachycardia. D. Dilated pupils.
Is B.
B.
B. Diarrhea.
Diarrhea and what?
Sweating.
Sweating.
Sweat. Please do some. If you are here, do some. Okay. Don't let us do for you. Do some. All right. So that is it. I think this will be our last question.
A client with myasthenia gravis is prescribed an anticholinergic medication such as pyridoxine. The nurse evaluates the client's understanding of the medication regimen. Which statement by the client indicates correct understanding? A. I can stop the medication when I feel better. B. This medication helps my symptoms but does not cure my condition. C. I will take extra doses if I feel weak. D. I should avoid taking it before meals. It's B. A.
The answer is B.
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 Between A and B, which one is the answer?
B.
It's B. B.
B.
So what about if I feel better? Can't I stop taking the medication? What am I taking the medication for?
That's my symptoms.
But the condition does not get cured, so
I've been taking the medication for long. Good. So that's the answer to my question. Okay. That's the answer to my question. Well done. All right. So this is the rationale. Okay. Now, to Brad Jacob, who was asking that question. So look at this one. I pulled out Parkinson's, Alzheimer's, and myasthenia gravis all here. Now, watch something. Parkinson's disease, we learned that it's a neurodegenerative disease or disorder, okay? Which means that it affects movement. So you see this one, like movement disorder. It's more of movement, okay? Look at Alzheimer's disease. It's also a neurodegenerative disease, but it's more of what? A cognitive disorder. It affects your cognitive issues, okay, or affairs. Myasthenia gravis is purely and authentically autoimmune neuromuscular disorder or autoimmune disease, simple. Now look at what is happening in Parkinson's. If you remember what we did, we said dopamine is low, so we have to give levodopa. Okay, that's something to raise it high, right? And in Parkinson's too, you have acetylcholine high. So you remember we give anticholinergics to, okay, in Parkinson's disease. Do you remember something to decrease the acetylcholine, then increase dopamine? Do you remember that part when we did it? Okay. But look at what is happening in Alzheimer's disease. Acetylcholine is low in the brain. Okay. In myasthenia gravis, acetylcholine too is also low, but this one is low in neuromuscular junction. All right. So main area affected is the basal ganglia. This one is cerebral cortex, the hippocampus first. Okay, and this is more of skeletal muscles. So Parkinson and Alzheimer will affect the brain more than myasthenia gravis. Okay. So look at the key symptoms. I'll let you look at that. If anything, don't forget about this word, shuffling gait. As soon as you hear shuffling gait, remember Parkinson's disease. Just as soon as you hear, shuffling gait. Okay. Remember Parkinson's disease. And the next one, we are saying there's memory loss here for Alzheimer's disease and personality changes, confusion. For this one, there's muscle weakness, fatigue, ptosis. So you see how the differences are. You can look through them, okay? You can look through them. So key feature in Parkinson's disease, there's shaking. Okay, there is shaking. Then Alzheimer's disease, there is forgetfulness. That's why you have to keep on orienting them, okay? Then in myasthenia gravis, there's what weakening. Okay. Now watch here. Parkinson's disease has no cure. It's manageable. Alzheimer's disease has no cure, and it's even progressive. Okay, can even move ahead to be worse. All right. Then the last one, my myasthenia gravis, it's manageable, can improve with treatment. Okay. All right. If you have any question on this one, you can ask. All right. Now, I know our time is fast spent. Let me just brush through this one with you. Just let me tell you something about it, then we bring it to an end, okay? Skeletal muscle relaxants. So we have two main forms, right? We have the one that acts directly on the muscles and one that acts centrally. Whenever you hear something central, it means it's happening in the brain, okay? So with the direct one, what it does or how it does its action is that it acts directly on the muscle fibers. So it reduces muscle contraction. As we are going through this, what medication is coming into your mind? Can someone guess?
You mean skeletal muscles?
Robazin.
Which one?
Robazin.
Baclofen.
Baclofen. Good. Good. I remember I remember baclofen. Okay. My mouth is dry. I remember baclofen. Good. Well done. What else do you remember when we are talking about these things? Look at how they work. There's one common drug. It's like everybody here should know. If only you are with USRN.
Is it
That's
Dantrolene?
the farm.
Dantrolene. Good. We've talked about diazepam already. Benzodiazepines. We've talked about them already. So dantrolene, good. So baclofen, dantrolene. Thanks for mentioning those drugs. So you get there, okay, very soon. So direct acting muscle relaxants, okay, they act directly on muscle fibers and they reduce muscle contraction, they reduce spasticity and muscle pain. They are used for spinal cord injury, they are used for stroke, cerebral palsy, okay, multiple sclerosis, and malignant hyperthermia. So you see malignant hyperthermia here. All right. All right. So some of these key medications we're talking about are dantrolene, okay, and botulinum, okay, botulinum toxins. So this is the only drug, okay, that is used for spasticity. That is why when you see kids like malignant hyperthermia, what's the other name? NMS, right? Neuroleptic malignant syndrome. In all of them there is muscle spasm, severe one. That is why it's being used to treat those conditions. Okay. Okay, and with the with the botulinum toxin, what is it right? With the botulinum toxin, we use it for what? Cervical dystonia and wrinkles, just to relax the muscles. Okay, so this is how they act by reducing synaptic transmission at muscle. So they act to relax muscles, simple as that. Okay, and they reduce the frequency and severity of the spasms. They relieve pain from involuntary contractions. Client teaching. Do not stop these medications too abruptly. You have to taper down gradually. Because they are highly metabolized by the liver, you can have jaundice, dark urine, abdominal pain, all of this happening. Please do not crash capsule. So take note. Do not crash capsule. Okay. Okay, so that is all for the direct. This is very short. That's all for the direct acting. Now, for the centrally acting, they act on the CNS. Okay. They do not affect the muscles directly. Okay, but they affect the central nervous system, especially the spinal cord, and they do not affect muscle directly, like I said over here, but they can cause muscle relaxation and sedation. Okay. All right. Indications: acute musculoskeletal spasms, muscle injury or inflammation, and it is not for CNS related spasticity. So the central one, baclofen, like what our sister mentioned. Um, did someone mention cyclobenzaprine? I heard someone mention that, right? Or, well, so these are some of the medications, okay? So all what this medication does is they slow down your CNS, okay? So that when a CNS is suppressed or it's slowed down, you will have effect on the muscles too. Everything is slowing. So side effects generally, you see drowsiness, dizziness, weakness. Okay, please, if you see dry mouth and you see xerostomia, it's the same thing. Orthostatic hypotension, tachycardia, GI upset, and this is very rare, but this could mean what? So you see this one, it's an adverse effect and can cause lots of issue. Okay. So when you are giving a centrally acting tool, you monitor CBC, liver functions, vital signs, CNS depression because they depress you or they bring it's like downness. Okay, that's how they work. So you have to evaluate muscle spasms if you are giving them. Okay, avoid driving. Like we said about all downness, you have to avoid driving. And the next one is do not stop abruptly. We've thought about this many times. Report severe weakness, okay, and allergic reactions. All right. Now, key things to take home here. Contraindications. Hypersensitivity is like a contraindication to every drug. Every drug I know. Okay. Liver disease, cardiac disease, and all of that. Okay, and children less than 12 months, there could be some that could be used, but please, when you get questions and the person is less than 12 years, look out for options that will better suit your answer. But have this in mind, okay? Other than that. All right. Now let's look at our right hand side, the English key points. So dantrolene, that's why you have a star attached to it. Dantrolene is mainly used for what? Malignant hyperthermia. I hope you all know what malignant hyperthermia is. Who doesn't know? So that you can clap for the person.
Yes, I don't know.
You don't know. Oh, okay.
Reggie, I don't know, please.
I also don't know.
Then I'm clapping for you, okay. All right. When we say malignant hyperthermia, normally people confuse it with okay, so to make it short, I've dropped the difference between malignant hyperthermia and NMS before in masterclass page. Do you remember? Is there anyone here who remember?
Yes.
Yeah.
We
So
remember.
they are very similar, okay? And what we will see in them is that you will see severe muscle contraction. I think it has a genetic predisposition. Okay, you see muscles contracting in a way that they generate heat within them. You can have severe fever. Okay, not fever as in infection, like because there is severe muscle contraction, the whole body. Yeah, you can have temperatures rising because of the contraction. So we use the dantrolene to treat these patients. We give it to them to relax the muscles in these conditions. I remember we have some anesthesia drugs. Where you see dantrolene being asked of is some anesthesia drugs, and I think it's mostly anesthesia drugs for um, neuroleptic malignant syndrome. It's more of is it antidepressant? No. Yes.
Yes,
Antipsychotics,
so
yeah, that's what I want. Yes, antipsychotics. Antipsychotics it's a bigger umbrella. So that's what I want to say.
No.
Yes.
yes.
Yes. So NMS mainly, okay, so that's neuroleptic malignant syndrome is mostly associated with what? Antipsychotic drugs. And malignant hyperthermia is more related to what? Anesthesia drugs. But in all of them, you can use dantrolene because in all of them, you can have severe muscle contraction that we are talking about. They are very similar, okay? Just that we have few differences. And I mean, the differences in the occurrence. But they all cause severe muscle contraction in the way that your temperature will go very, 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 very high. And please, nothing can make you go down or be recovered. Just get your dantrolene shots and you're okay. Okay,
Please,
so
what
yeah.
about? Okay, continue. Continue. I don't want to.
What about you?
I
Okay.
wanted to ask something, but maybe you mention it, so let me keep.
Okay. All right. So that is it. And we've talked about direct acting being a drug that acts on. I mean, those that act on the muscles directly, and central acting act on the CNS. Okay. Major problem or concern with these medications are, or it's mainly hepatotoxicity. Okay, that's the main concern. Okay, so you see this one, we are saying sedation is common for all muscle relaxants. Okay, do not stop abruptly. It's also there. Look at this one. So direct acting here, centrally acting here. I give examples. So sites of action. The direct acting, they act on the muscles. Centrally acting, they act on the CNS. Okay. Example of direct acting is dantrolene. Example of centrally acting is what baclofen. So when you see baclofen, dantrolene, they all reduce muscle spasm. Baclofen affects the CNS. Okay, it affects the CNS to do that. And dantrolene affects the muscles directly. So with the use its spasticity, okay, muscle spasm or key risk factor hepatotoxicity, and this one CNS depression. The rest are my questions. Then we can go. We can go home safely. Okay.
Okay, please, my question now.
Yes, ask your question now.
There's this drug called bromocriptine. Is it also indicated in
You said what?
this bromocriptine? Is it also indicated here?
Bromocriptine.
Yes, please. Can you also?
I'm not too sure. For these drugs, they are very dicey. I'm not sure. Like bromocriptine helping to reduce muscle spasm. Is that what you are saying?
Yes, please.
No, I don't think so. No. Or anyone who thinks otherwise, I don't think so. Why? You've seen it somewhere before?
Yes, please.
Oh, you're not talking. That bromocriptine helps to reduce muscle spasm.
Yes, please. I've seen it. Yeah, I've seen. Yes, I've seen it before. That's why I'm
You're saying it's
just to be
a
sure.
dopamine receptor, a dopamine receptor agonist and an ergot derivative, primarily used to treat hormonal imbalances and neurological movement disorders.
Mm,
Me, I saw
because
it
bromocriptine
somewhere
there,
that
no.
it's not really a muscle relaxant like this ones, but I think it's also used for these extrapyramidal effects you see with antipsychotics.
Good. If something like that, but please, this muscle contraction we are talking about in NMS and MH, like malignant hyperthermia, please, they are dangerous. It's an emergency. When you get these conditions in prioritization questions, please, it's emergency. Okay, these things, well, I don't know if someone here have seen it before. Who have seen malignant hyperthermia happening before? I've seen it once, only once, back in Ghana. Okay, and it was dangerous, right? It's very severe. And because you have muscle breakdown, you can have, when muscles break down, what is being released? Lactic acid, right? Is it lactic acid?
Yes. Oh.
Where are scientists?
Yes.
Scientists, are you all tired? Yes. So I think lactic acid is released into the blood, and they all cause stress to the I think potassium, potassium too is released from muscles, potassium, like harmful substances, lactic acid, and they all causes strain on the kidneys. You can easily get kidney failure as a complication of this malignant hypertension if not treated early. Okay. All right.
Uh, please. So can
Yes,
this
sister.
also cause rhabdomyolysis? Something.
Yes.
Mhm.
Rhabdomyolysis, right? Something like that.
Myelus.
Rhabdomyolysis
Yes.
is like breakdown of muscles, right?
Breakdown of muscles.
And yes, and when you have breakdown, yes, when you have severe contraction, you have some of the muscles breaking down. So it is innate, okay? and you have similar thing happening. So just imagine how rhabdomyolysis happens and the effect to the kidneys is similar to how malignant hyperthermia 2 will affect the kidneys, okay, and NMS. So they are all in the same direction, something like that. So it's like you are coming from, it's like you're going you are traveling from Accra to I don't know, Accra to Mercy Road. Okay, let me say Accra to Cape Coast, right? When you get to let's say from Kaneshi to Cape Coast, when you get to Kaswa, someone will join. When you get to Winneba Junction, someone will join. When you get to Magasin, someone will join. So they are all in the same direction, something like that. Okay, let us solve these questions quickly so that we can go. Our time is up. Can someone read for us?
A client is prescribed dantrolene for spasticity. Spasticity.
Yes, carry on, okay?
Laboratory value is most important for the nurse to monitor. A potassium, B,
What's the
hemoglobin,
answer?
C, enzymes, blood glucose.
Liver enzymes.
Liver enzymes. That's very easy. So this one is going to be very quick because they are not difficult. The next one.
A client taking baclofen reports dizziness when standing. What is the best nursing action? A. Encourage bed rest. B. Discontinue medication. C. Teach client to rise slowly. D. Increase fluid restriction. C.
You all agree to C? That's also very easy, right? Is someone saying A?
No, C.
Okay. The next question. Kindly mute up. P. There's a P. There's someone called P here. Okay, carry on.
This client is contraindicated for centrally acting muscle relaxants. A. Client with diabetes. B. Client with anemia. C. Client with history of myocardial infarction. And D. Client with mild hypertension.
Wait, don't say the answer. Let me pick someone at random here and ask. Adoma, are you here? Please, when I mention your name, don't get lost. Adoma, what answer will you pick?
I'll go for C.
C, which is client with history of what?
Myocardial infarction.
Okay. Do we all agree?
Yes, sir.
Okay. Okay, thank you, Adma. So that is it. All right, the next question, and I'll call another person. Read for us.
A client receiving dantrolene reports yellowing of the eye. What is the next priority action? A. Reassure the client. B. Encourage hydration. C. Administer next dose. And D. Notify healthcare provider immediately.
Okay. Annette, are you here? Annette doesn't want to talk. Some people, when I mention their names, then they'll just leave. Amasaki, let's go.
In fact, we're doing more.
No problem.
Sorry.
No problem. Amasaki, no problem. Okay. Amasaki, are you here? Okay, Abigail. Okay, Adjoa. Hey. All right. Anyone?
The answer D.
Notify the
The
healthcare
answer
provider
is D.
immediately.
The answer
Yeah,
is
I will
D.
notify the healthcare provider.
Notify the
D.
healthcare provider.
Okay, that is D. That is correct. Okay, that is correct. Okay. So someone will not talk, but the person will call or will give us a ring, right? Okay, no problem. We are almost ending it. Yes, the next question.
A client Which nursing interventions are appropriate for a client on muscle relaxants? A. Monitor liver function test. B. Assess level of consciousness. C. Encourage abrupt discontinuation. D. Monitor intake and output. And E. Assess for muscle.
Assess level of consciousness.
Is it a
So
SATA
this is
question?
let that apply. Let us do it together. And the first one,
Monitor
is
liver
this part?
function test. Yeah.
Is A part?
Yes.
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 Yes, A is
Is
part.
B part?
Yes.
Yes.
It's C part?
No.
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 It's D part?
No. No.
Intake and output.
It's E part?
Yes.
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 Okay. So let us see if we are correct.
Liver function test.
Yes, we are correct. A, B, and E. Okay, that's the rationale for us. Okay, that's the rationale for us. All right. I think here is where we end neuromuscular and skeletal muscle medication. Okay.